A newborn infant presents with excessive drooling, choking, and regurgitation during the first feed. I am showing you the chest radiograph. Describe the findings.
Okay, I see it. The chest radiograph demonstrates a radiopaque feeding tube that is coiled within a gas-distended, blind-ending proximal esophageal pouch. There is gas seen below the diaphragm within the stomach and bowel loops, which indicates a connection between the trachea and the distal gastrointestinal tract. No active consolidation is seen. These findings are diagnostic of esophageal atresia with a distal tracheoesophageal fistula.
Explain the embryology, classification, and most common subtype of tracheoesophageal anomalies.
Well, these anomalies result from a failure of the primitive foregut to septate into the anterior trachea and posterior esophagus during the 4th to 5th weeks of gestation. The most common subtype, accounting for approximately 80 to 85% of cases, is esophageal atresia with a distal tracheoesophageal fistula. Other subtypes include isolated esophageal atresia without a fistula, which presents with a completely gasless abdomen, and the H-type fistula without atresia, which can present later in childhood with recurrent chest infections. The second contrast film illustrates a distal tracheoesophageal fistula, where water-soluble contrast injected via the feeding tube passes from the esophagus into the trachea.
What are the key clinical complications and the significance of abdominal gas in these neonates?
Okay, the presence of abdominal gas is critical because it confirms the presence of a distal fistula as air from the trachea passes down into the stomach. Conversely, a gasless abdomen indicates either isolated atresia or atresia with only a proximal fistula. The major clinical risk is aspiration pneumonia, resulting from saliva overflowing from the blind proximal pouch or gastric juices refluxing through the distal fistula into the lungs. In addition, these anomalies are strongly associated with Vactal syndrome, requiring careful screening for vertebral, anorectal, cardiac, renal, and limb defects.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these findings with antenatal maternal ultrasounds, which may show polyhydramnios and an absent stomach bubble. I would suggest screening for associated vactural anomalies, specifically checking for vertebral defects on the chest film, and recommending a renal ultrasound and echocardiogram. I would recommend keeping the patient in a prone position with continuous suction on the proximal pouch to minimize aspiration risk. Finally, I would document the findings, evaluate for aspiration pneumonia, and refer the patient immediately to pediatric surgery for surgical repair.